Hello, everyone. My name is Matt Stanton. I'm one of the clinical toxicologists at the Wisconsin Poison Center. Today, we are going to be talking about household products and miscellaneous over-the-counter substances. This is obviously a large topic and likely not all-inclusive of what you could see on the exam. Some of the material in here has been covered in other lectures. Some of it may be new. I will point out material that has been covered elsewhere and not going to detail regarding that content. Likewise, a lot of the substances on here are what you manage on a day-to-day basis. So most of these should look familiar. Not all of them in detail are in some of the textbooks, and you may have to use other resources such as Poisondex. With that, let's begin. Today, we're going to describe the toxicities of miscellaneous household products and decide in home management of miscellaneous household products. We're going to start with fire extinguishers. Obviously, we don't get serious effects from this, probably mostly because there is just a slight inhalational exposure, which many of you have probably already seen. There are several different kinds of fire extinguishers. Some are foam, some are powder or wet fire extinguishers, and some are dry. They all have varying substances in them depending on what type of extinguisher it is. Foam extinguishers can have alum, which is alums are just double sulfated aluminums. They could have sodium bicarbonate. Some of them could even have ethylene glycol. Powder can be sodium bicarb, ammonium phosphate, and some dry ones could be borates. Borate exposure is covered in a separate lecture. Regardless, all of these are irritants, and most of the exposures you will see are inhalational, and supportive care is all that is needed. Ingestion is rare. If you do get ingestions of these, generally, um, depending on the product, you'll most likely see some electrolyte disturbances, which you should treat accordingly. Treatment depends on the substance, obviously. Decontamination should always be considered. You remove the patient from the area, and like I said, supportive care. Aluminums or alums could be treated with deferoxamine, and then borates and electrolytes could be dialyzed. Moving on to button batteries, these are also called disc batteries. The larger sizes get lodged in the upper airway or the GI tract, and they can cause burns and perforations. And most of you have probably experienced cases of this before. The larger the battery, the more likely it is to get stuck. If you think about a pediatric patient with a tiny, narrow esophagus, greater than 20 millimeters is of the most concern. Granted, smaller ones can also get stuck. So the majority of these should be sent in for an x-ray. There is the button battery hotline that is available if you ever need it. Keep in mind, 25 millimeters is about an inch in diameter. So 20 millimeters is still a pretty large button battery. So obviously that's where the concern comes in. Management, again, send in for x-ray. These patients might need endoscopy removal if it's lodged pre-pylorus. If it's post-pylorus, for the most part, they don't get stuck, but there's going to be need for follow-up x-rays. If a pediatric patient gets it stuck in their nose or ear, those should be removed because the same issues of the membranes connecting the poles of the battery, and they can cause burns. You can use honey or sucralfate in the meantime of getting a patient to the hospital, and this has actually been shown to be evidence-based. If the child is less than 1 year old, we avoid honey, and the dose is just 10 mils every 10 minutes for a few doses. All right, moving on. We have a 38-year-old male case of epigastric pain, weight loss, recurrent vomiting, has a history of HIV, schizophrenia, latent syphilis. Medications include haloperidol, benztropine, risperidone, nalfinavir, and zidovudine lamivudine. The case has been published, so there's the PubMed ID number for you. The treating team decided to get an X-ray and found several foreign bodies in here. These ultimately were discovered to be coins. So this is a rare case of a massive coin ingestion. You can get zinc toxicity from coins, and then the zinc toxicity can cause copper deficiency. These can also have local corrosive effects. All organs can be affected. It can cause a coagulopathy, and massive coin ingestion. Obviously, you should get surgical removal. Majority of the cases we see in pediatrics, the one single coins are usually the large aspiration concern. Obviously, there's no aspiration event. They probably don't need to go in the hospital to get treated. They should get connected with their primary care and probably get follow-up X-rays until passage of the coin. Like I said, you can get copper deficiency or zinc toxicity, and copper deficiency should maybe be a consideration for a large coin ingestion when you're thinking about a differential. May need endoscopic removal or surgical removal, obviously, like I stated previously. Similarly, magnets could be a potential concern. Again, aspiration is the main concern. One magnet generally is fine, not that big of a deal, and obviously unless it gets lodged somewhere. More than one magnet, that's where the concern comes in. So magnets could connect in somewhere in the GI tract and pinch some of the lumen of the bowel and possibly cause necrosis. That's where concern comes from. So more than one magnet concern, a magnet with a metallic foreign body, also a concern. These might need endoscopic removal if there's a concern for aspiration, but there's potential for surgical removal as well if there's more than one magnet or a magnet with a metallic foreign body. Moving on to holiday hazards. I'm not discussing all of the holiday hazards that you could encounter as a spy. For example, 4th of July, we usually discuss fireworks. I'm not going to be discussing fireworks here because there are potential for fireworks at other times of the year, like New Year's, for example. And a lot of these holiday hazards can happen at pretty much any time of the year. So I'm going to cover a couple that I think are the most important, but you should be aware of several other ones. So what I'm going to cover are bubble lights. Bubble lights contain methylene chloride. This is an example of what they look like if you're not familiar. Methylene chloride is metabolized via cytochrome 2A1 in your liver to carbon monoxide. Treatment is 100% oxygen, possibly hyperbaric oxygen that has been used in case reports. Another holiday hazard is mistletoe. There's a couple different types of mistletoe, European and American. Holly contains saponins. Again, treatment supportive. They have GI effects, rare seizures. And then there's potential for hemolysis with saponins, but again, it's incredibly rare. They're most likely GI effects with these. Some mistletoe and some holly. Similarly, around other holiday hazards, there could be glow sticks. When glow sticks happen at a number of different holidays, we usually think of them over the summer months. Glow sticks contain dibutyl phthalate, which is an irritant. Dilution is the treatment, and again, generally, there's not significant potential here. Likewise, as disgusting as it might be, we get calls about feces, which again, maybe could happen year round. GI effects are the biggest issue with kids eating feces, but there's always potential for bacterial or viral infections. You can think of it as a potential food poisoning. All right, moving on to vitamins. Most vitamin toxicity is going to be from chronic use. It is extremely rare to have an acute exposure that cause significant effects from a vitamin. Vitamins are used throughout our bodies. Our body usually uses whatever amount of vitamin they need, if it's a one-time large dose, and then you eliminate the rest of it. Obviously, with vitamins, multivitamins, you should be watching for iron, but that's covered somewhere else in a lecture. Random vitamins that we usually discuss of and we know some effects for are vitamin A, which can cause hepatitis and some dermatologic problems. There's also increased intracranial pressure associated with it. Vitamin C cause oxalate crystals and potential hemolysis. Vitamin D and can cause hypercalcemia in large repetitive doses, GI symptoms, weakness, potential for mental status change. Vitamin E, again, GI symptoms, headache, weakness. Don't forget the e-cigarette vaping and acute lung injury problem we had from vapes, and this was vitamin E acetate. So inhaling vitamin E could be a potential problem as well. Vitamin K given to newborns can cause hemolysis, but again, we use vitamin K to reverse vitamin K antagonists. Niacin is also vitamin B3. Anytime you counsel a patient on using niacin, generally for their cholesterol, we talk about skin flushing, potential for gastrointestinal symptoms, and there have been cases of hepatitis associated with it. Pyridoxine is vitamin B6, which actually can cause a peripheral neuropathy if you excessively take it. Interestingly enough, we give it for patients that are taking isoniazid chronically to prevent peripheral neuropathy, but it can also cause a peripheral neuropathy in chronic doses. Riboflavin is vitamin B2, and really the only issue that we ever see from that riboflavin is yellow perspiration. Moving on to lacrimators, and this is going to be capsaicin. Capsaicin is the main ingredient in chili peppers, which is also potentially used in pepper spray, hence the name. Obviously, this can cause intense irritation, but it's used as a medication for muscle or joint pain, possibly even cannabinoid hyperemesis. We rub it on patients' stomachs to relieve some of the symptoms from that. Treatment is really just supportive. Obviously, decontamination as best you can with water or milk. Maalox can be used topically as well. Moving on to another case, a 40-year-old ingests a chemical at home in an attempt to harm. They have hematemesis, oral burns. They get some labs. They find they're hypocalcemic, hypomagnesic, and hyperkalemic. Which substance do you most likely suspect? If you're thinking fluoride or hydrofluoric acid, you would be correct. Fluoride is obviously found in many dental products, so it's also still found in chemicals as hydrofluoric acid, generally used as wheel cleaners and chrome cleaners in industry. Historically, sodium fluoride had been used as a rodenticide as well. It can be absorbed via ingestion, dermal exposures, and inhalation. It is hydrofluoric acid is an acid, but it's a weak acid actually. So it's treated differently than other acids. Mechanism of toxicity is the chelation of magnesium and calcium, which usually gives you the intense pain that it causes, getting it on your fingers or in a different area on your body. Hyperkalemia is from the red blood cell destruction and tissue destruction. It can create reactive oxygen species, which can cause cell damage. It's a disruptor of ATP synthesis. So it can be really bad, and it obviously depends on the concentration and the amount that the patient is exposed. Chronically, there's skeletal fluorosis that has been noted, but we don't really worry about that from a poison center standpoint. Pain is obviously a large thing that we see many cases of, and it's usually pain out of proportion, right? It looks like not a large wound, but there's intense pain that patients can have. GI effects, obviously, if ingested. The electrolyte disturbances can lead to ventricular dysrhythmias. It is caustic, so you have those issues to worry about, and it could be a respiratory irritant if it's inhaled. Generally, for the most part, as a specialist, you're dealing with a lot of toothpaste ingestions or other dental products. Even toothpaste in large doses is probably not a big deal, and that's listed there, that PubMed ID for you to look at. Fluoride management, severe cases need decontamination. Topical exposure can get topical calcium gluconate gel. It's 2.5%. And I put the formula on there to remind you how to make it, or one way to make it. Just 25 mils of 10% calcium gluconate given in 75 mils of a water soluble lubricant like Surgilube or KY jelly. Um, Ophthalmic exposures should just get irrigation with the usual things we irrigate, normal saline, lactated ringers, or just water is fine. You shouldn't use calcium in your eyes. Inhalation, there is potentially you could use calcium here, and this is a nebulized 2.5 calcium gluconate nebulizer, which could be used, but other routine inhalers could be used as well. Ingestion, this is the odd part. Because we know the systemic toxicity is so bad, there is potential here where you can give oral calcium, and this can bind fluoride in your GI tract. We generally don't do that with caustics, but this is something that could be considered. And then if you have electrolyte disturbances systemically, from whichever way you get exposed, you can give calcium and magnesium intravenously, in some cases, even empirically, if you know the exposure was there and there is reason enough to suspect there are calcium and magnesium disturbances. All right, moving on to antiseptics. Antiseptics, I'm just going to go through a couple definitions just to keep those in your head. An antiseptic is use on a living organism to kill microorganisms. So this is stuff we put on our skin, or we're supposed to put on our skin as an antiseptic because we are living organisms. Disinfectants can use the same chemicals that we talk about as in antiseptics. Usually the concentrations are what makes it disinfectant versus an antiseptic, though. So use on inanimate objects like tables, phones, right? Not a living organism is a disinfectant. And there could be different chemicals. There could just be concentration differences in chemicals. Here is a list of the antiseptics and disinfectants we're going to be talking about. Several of these have been covered elsewhere, so I'm not going to go into much detail. Hydrogen peroxide has been covered, and that's what the asterisks are for. Hydrogen peroxide has been covered. Iodine's been covered. Mercurochrome is an old antiseptic, but you already discussed mercury in a different case or a different lecture, and phenol is mentioned in another lecture as well. So those I am not going to review. I'm going to first discuss chlorhexidine. Chlorhexidine is used commonly in hospitals. It's a mouthwash, dental rinse, which is the concentration that I have here, the 0.12%. At higher concentrations, like 4%, can be used as a skin cleanser. Systemic absorption is minimal, but you could get some systemic absorption at higher concentrations, and it could be a caustic at higher concentrations. The low concentrations that we use routinely for mouthwashes are usually not that big of a deal and maybe an irritant at most. There are cases of methemoglobinemia, again, with large exposures or high concentrated exposures. It's used to disinfect, like I said. These can be disinfectants and antiseptics. It is an irritant, potentially caustic, and care is just supportive. The other two I'm going to be talking about are hexylresorcinol, which you can really think along the lines like phenol. It's related to phenol, but it's much less toxic. It's used in the same manner as like a throat lozenge or an antihelmintic. If you get a case of this, it's just supportive care. Ichthymol is a cherolytic. So this is an astringent that you can apply to skin to rub off the keratin layer of whatever you're trying to you're trying to treat. So it's a cherolytic to tissues. It contains 10% sulfur, which shouldn't be a big deal, but again, doesn't really change much with care as it's just supportive. All right, now we're moving into the essential oils. We're going to start with camphor. Camphor is an essential oil. It's used for religious, spiritual, aromatic. It's an aromatic used in folk medicines, also a potential repellent like mothballs. Also used in the classic Vicks products, which you get many exposures about. It is a CNS stimulant, causes seizures and seizures soon after ingestion. So it's one of those products that I think of that can cause seizures relatively rapidly. Everyone talks about the toxic dose being 30 milligrams per kilo. Acute ingestion, obviously, it could be an irritation, GI symptoms. You could get other neuro symptoms like dizziness, confusion, hallucinations. Is an aspiration risk since it's an oil. Chronic exposure, which I've never encountered, but there's been cases of myocarditis, hepatitis, and death. And then dermal exposure, you can obviously get flushing, allergies. There is potential for seizures here too, since it is systemically absorbed. Treatment's just supportive, though. Treat seizures, aspiration. It's rare to see significant problems with these nowadays. Moving on to another oil, methyl salicylate, an oil of wintergreen. You remember this contains about 7.5 grams of aspirin equivalent per teaspoon. So a lick or a taste of this could be a significant amount in a pediatric. Doctors also did a great salicylate management lecture, which you should refer to for treating these. And these are found in things like Bengay or other essential oils you can find online. Obviously, there's a lot more essential oils. I'm not going to go into each one individually. You should be familiar with a few main ones, and I would like to remind you that pennyroyal oil and clove oil are probably the worst you could see because they have larger systemic effects. That could be caustic. They also could be they could have liver toxicity as well. So it's something to consider. And we just use NAC if you have any of those exposures, severe exposures. Obviously, we just manage all of these hydrocarbons as essential oils. We manage as hydrocarbons. They can all cause irritation, though, at the end of the day, and potential for GI symptoms, obviously. This next slide, I have listed a large array of essential oils. Again, the ones I would probably consider focusing on would be clove oil that contains eugenol versus like eucalyptus, which contains eucalyptol. So at least you have a word association there when you talk about some of these. Melaleuca oil is tea tree oil. And could be associated with some effects. Nutmeg has myristica oil or myristicin, which is amphetamine-like substance. It can cause hallucinations, agitation, seizures, tachycardia. Pennyroyal oil, I mentioned already. It's responsible for systemic toxicity, including death. It's also historically used as an abortifacient, so keep that in mind. Wormwood is another one I would think about that contains thujone, which is found in absinthe, and this can cause seizures, hallucinations, agitation. So those are probably where I would focus a lot of my study time on are the ones that have more significant effects, and maybe we have some potential for treatment or at least potential for like treatment. All right, moving on to cough and cold preparations. We're going to be talking about dextromethorphan, benzonatate, and pseudoephedrine, phenylephrine, ephedrine. We're not going to be talking about antihistamines, acetaminophen, and salicylates. Granted, you should keep in mind that these are all found in cough and cold products, but these are covered in other lectures. So we're going to be discussing first dextromethorphan. Dextromethorphan is metabolized to dextrorphin, which is an actual opioid. It is not one of the more potent opioids. It is related to a drug called levorphanol, which is another opioid. Dextromethorphan has selective serotonin reuptake inhibitor properties. It's also an NMD receptor antagonist, similar to ketamine or PCP. Some products contain hydrobromide salts, which contain bromide and can cause bromism. Bromism really has a similar presentation to alcohol withdrawal or benzodiazepine withdrawal. It does cross-react with PCP on a urine drug screen because it is structurally related to PCP and ketamine. Clinical effects, obviously GI symptoms, you can see mydriasis or meiosis. You can see nystagmus, which we classically see with a lot of ketamine patients. Can cause agitation and euphoria because people like to misuse it for the euphoria effects. Could cause seizures and hyperthermia, coma and death, and some of this is probably related to the serotonin toxicity since it is an SSRI. Treatment, could you use naloxone? Possibly. Generally, just supportive care is fine, and treating potential serotonin toxicity is all you really need to do. Moving on to benzonatate. These are the brand Tessalon Pearls. This is a local anesthetic. So local anesthetics are sodium channel blockers. You could consider benzonatate in the one pill can kill treatment thought. Granted, there are cases of patients getting exposed to this and not having any significant effects. It might depend on the dose. Maybe depends on the weight of the child as well. But it does come as a 100 and 200 milligram capsule. So maybe the 200 milligram capsules are more the ones that can cause issues. Initial sodium channel blockade effects you could see, or mild effects could be perioral or oral numbness. You can get headache. You could get confusion. The more serious effects from a cardiac standpoint are wide complex tachycardia from the sodium channel blockade. This can cause seizures, can cause death, just like other local anesthetics. The treatment is IV lipid emulsion. This is something else I put on my differential of something that can cause seizures relatively quickly, like camphor. So my quick list for a seizure after an exposure, soon after an exposure, would be benzonatate and camphor, along with other local anesthetics potentially. Moving on to the nasal decongestions, these are what we classify as sympathomimetics. Phenylephrine was removed from the market somewhat recently. This may cause hypertension, but again, oral phenylephrine I don't think really ever caused significant effects. IV phenylephrine can cause hypertension. Phenylpropanolamine was an old decongestant that was taken off the market because it can cause hypertension and actually increased in intracranial hemorrhage. Ephedrine, which Chinese supplement name for it is Ma Huang. It's a performance enhancer and is banned from many athletic sports. Pseudoephedrine is obviously used in methamphetamine manufacturing. It's kept behind the counter for that reason, and this does cause hypertension and tachycardia if you take too much. These all work as an alpha beta receptor stimulator, right? So these can cause peripheral constriction by alpha 1 receptors in your periphery. It can cause tachycardia from beta 1 receptor stimulation in your heart. So you could see stroke, myocardial infarction. Like I mentioned, they can cause intracranial hemorrhage. There is potential for Brady dysrhythmias. Again, if you get more alpha stimulation, your body's reflex will be to cause a reflex bradycardia. And we sometimes actually see this with IV phenylephrine in the hospital. If you increase blood pressure, you get this decrease in heart rate. Treatment for these benzodiazepines, we generally will avoid selective beta blockers. And this is where you could use other vasodilators, nitroglycerin, for example. You could use phentolamine, which is just an alpha blocker. So you can kind of sometimes think of these similar to cocaine. Moving on to nicotine. Nicotine is a plant, remember, from tobacco. Obviously, you find in cigarettes, cigars. We have pharmaceutical nicotine and lozenges, patches, gum. They're in electronic cigarettes nowadays, which the concentrated nicotine liquids for the e-cigarettes are probably where the majority of the issues we have come from. Now, I have this picture on here. I don't want to scare you with this, but on one side, we have the sympathomimetic effects that you can see from sympathomesis. On the other side here, you have parasympathetic effects. And these are, again, for your central nervous system. And then your other somatic motor nervous system is another piece to this that we need to talk about. You'll find nicotinic receptors at all of these nervous systems, which again is responsible for all the array effects that you can see from nicotine. So you have to remember this specifically, but depending on the dose you get, you can see a different variety of effects. If you've ever been exposed to low dose nicotine as perhaps smoking a cigarette or a cigar, you sometimes feel maybe a little bit dizzy. You'll get some tachycardia possibly. But as that dose increases, you can actually see more parasympathetic and somatic motor nervous system effects. So nicotine, kinetics, it's rapidly absorbed in the GI tract. You can also get dermal exposures. And we talk about this with green tobacco sickness from tobacco workers. Many references will talk about 1 cigarette or 3 butts should be considered toxic to a child. This is a low threshold to send these kids in. I've had kids that get this amount and nothing significant happens to them. Obviously, it's disgusting, and they might get sick. But so sometimes children can tolerate more than this, but this is a low threshold and something you'll see referenced everywhere as a potential toxic dose to a child. The effects, like I mentioned earlier, depend on the dose. So at lower doses, you can see all of these nicotinic effects, right? So in GI symptoms, you get diaphoresis, hypertension, tachycardia. You can see mydriasis here. So these are some effects you can see at the lower dose, and sometimes even just if you want to consider this a therapeutic dose in some cases, depending on how you're taking your nicotine. The muscarinic symptoms and the somatic motor nervous system symptoms are at much higher doses. So this is where usually you'll see the Brady dysrhythmias, confusion, seizures. You can get respiratory paralysis, and then death. The somatic motor nervous system, you can see muscle fasciculations and weakness. And again, relates to the weakness and respiratory paralysis that you can see too. So that's a really high dose. And again, generally the e-cigarette liquid nicotine with these higher concentrations is where we run into problems. Moving into fertilizers and plant food. Fertilizers contain a different combination or some combination of nitrogen, phosphorus, and potassium salts. Some nitrogenous compounds can cause hemoglobinemia, although this is relatively rare. Some fertilizers contain ammonia as the nitrogen source. Anhydrous ammonia you can see in these large tanks, sometimes on farms that are used for the nitrogen source, and those could be caustic if you inhale that. Massive ingestion, you can get electrolyte disturbances, obviously from the different electrolytes in the salts. Generally, for the most part, fertilizers and plant food are all just GI irritants. Not usually that big of a deal. Care is just supportive unless you have methemoglobinemia, which again is covered in a different lecture. All right, the last section are personal care products. And obviously, this is another large section within a larger topic here. So this is the list of substances. I am not going to go in depth in all of these. I did make a table here for you to study from, and for the most part, like these are in certain containers that don't offer a large dose for someone to ingest. Now, if and majority of these are obviously pediatrics. Now, certain things like some hair care products that contain potassium or sodium hydroxide, those in smaller amounts could be problems. The perfumes and colognes contain ethanol, so we just treat these as ethanol poisoning and or potential ethanol exposure and give these kids some sugar to drink. Powders may contain talc, and this could be used for lubricants, adsorbents, protectants. Most of these are probably inhalational, and again, it's just going to be good supportive care. Suntan and sunscreens contain usually some oxybenzone, but they also contain salicylates. Salicylates are covered elsewhere, and generally, if there is a significant exposure, the concern for salicylates, if there is a significant exposure, you should consider salicylate toxicity, but it's really rare outside of that. Diaper rash cream contains zinc oxide generally, and this is, again, something we encounter multiple times a day. So again, you can use this as a study tool. I'm not going to go into each one in detail because some of these are discussed in other places, but you should still be aware of potential issues with all of these if you get a case on the CSPI exam. So with that, thank you very much.